Is there anything that we have missed that you want to make sure that we leave our listeners with?
I think it's always the admonition to, as ENTs, this is our disease to really quarterback. We have so many good colleagues in other adjacent specialties that can help us, but really it's our anatomy. And I encourage us to be more proactive, both with our physical exams and just our communications of the importance, especially of nasal obstruction in treating obstructive sleep apnea, especially, Ashwin, as you said at the outset, CPAP failures, but oral appliance failures too. I mean, I have a lot of really sharp dental colleagues that have recognized that on their own. When they're not having the results that they expect with an oral appliance, they send them back and say, take a look at their nose and make sure they have good airflow. And sure enough, 70% of the time, that can be improved. And then magically the oral appliance works better. So I think the whole point of this tonight is to really remember the nose in treating these patients.
Yeah, if I could leave with one thing, I think, Kieth, you said it perfectly. One thing I didn't touch on, and this gets into a little bit more sleep, is the AHI as a measure of disease severity. So the AHI it's a flawed metric, and anybody will tell you that. It combines apneas and hypopneas and divides them by total sleep time. So a hypopnea is scored the same as an apnea. So somebody can have a really high AHI and not really have that severe of a disease burden, where somebody can be having really bad desaturations, have a whole lot of hypoxia, and their AHI is actually lower. Treating the nose will improve a patient's quality of life and improve a patient's ability to adhere to any other OSA therapy. So don't bank on just the AHI going down, because sometimes it's not that. And I caught a lot of flack
Great point.
from other sleep physicians for Inspire, for other things I've done, where the AHI didn't get to zero and it didn't get to as good as I'd wanted it to. But the patient in the chair says, I sleep so much better. I feel so much better. My blood pressure's better. Everything's better. There's more to it than just the AHI. You need to look a little bit closer at the hypoxic burden. What is driving the AHI? Is it hypopneas or apneas? And what is the patient saying? So nasal treatment is extremely effective for all the things around sleep apnea. And it's effective somewhat for AHI too, but it's so much more effective for making anything else work better. So I believe in it.
Well said.
So if the AHI, if you haven't seen a lot of improvement, but the patient is telling you, I'm sleeping better, I feel better, and there aren't other alarm bells, you could potentially stop.
Look at the oxygen, right? The hypoxic burden, what we're talking about is the time that a patient is under 90%, essentially, however you define it. As you said, Ashwin, someone may only have 5 apneas an hour, but if they're each 2 minutes long, they're going to spend most of that hour under 90% and down in the 60s and 50s, right? But that's only an AHI of 5. And that's an extreme example, but that's possible. That's why the AHI is quite flawed in looking at efficacy of treatment. But if you look at the patient's oxygen throughout their sleep time, then you really know a lot about the quality of sleep. You got to look at their EEG, you got to look at a lot of other parameters, but I think if you had to pick one thing, if you know their oxygen is above 90% or higher, then their airway's open and they're respirating. I mean, that's maybe too commonsensical, but I think that's what it's all about, right? Breathing and oxygenating.
Yeah, I meant it to say, don't be dissuaded of any sleep intervention based upon a modest reduction in AHI, because there could be more to it. You could have converted really bad apneas, like you're referencing, into a couple hypopneas for every apnea, but now they're not desaturating. But your sleep colleague might just look at that AHI and say, it didn't budge, what you did is bogus. But it's not, because that patient's going to say, I feel better, I sleep better, things are better. Thank you. So that's what I'm saying, to look at the treatment as a process that involves the patient and how they feel, rather than just an AHI number. So your question, if you did the intervention and the AHI is still there, I look at it like, I'm not a jailer. I don't tell people what to do. I just kind of educate them about their health condition. So any AHI, the long-term data it also has its caveats, but what we seem to know is moderate to severe OSA and AHI over 15 will lead to long-term health consequences, where below, maybe not so much. So I tell them that, and if their AHI is over 15, we think about going to the next step, whether that be retrial of CPAP, some type of surgery, or making a device or referral, something like that.
While also recognizing that one AHI is not the same as somebody else's AHI, even though that's been the measure that has been chosen for OSA severity. There's more to it. Look at more than just that one number.
Yeah, unfortunately, that's the rules we got to play by, because that's what gets approved and denied based on that one number.